Okay. So you people can see me, right? Just drop a thumbs up or chat. Say okay. Okay. Archini, can you see me and hear me? Okay. See, today we are here. Hi, Chivas. Welcome to MDS Chivas. Myself, Dr. Vikram. Today we are here for the discussion topic of osseointegration. See, the osseointegration versus fibro integration is one of the very important either 4 marker or also in a NEET MDS question that is most commonly being asked. According to Brainmark, Zab, and Albexton, osseointegration is a direct, structural, and functional connection between the ordered living bone and surface of the load carrying implant. That is, according to these three, the spine is the osseointegration is a direct structural and functional connection between the ordered living bone and surface of the load carrying the implant. That means, see, it is a direct connection between the implant with the surrounding bone without any intervening tissues. Okay, simple. Definition wise, then coming to the brain marks histological point of view, it is a direct connection between the living bone and load-carrying endo-osseous implant at the light microscopic level that we see in the see because in the microscope only we can see the micro there is like a the connection between the bone and the implant, right? So thereby the microscopic connection between the load-carrying endo-osseous implant and the living bone is called as uh, osseointegration according to the brain mass histological point of view. And according to the GPT, that is like osseointegration is defined as, yes, hello, is there having any discrepancy? Okay. Then, according to the GPT terms, the osseointegration is defined as the apparent direct attachment or connection of osseous tissue to an inert alloplastic material without intervening connective tissue. See, the GPT terms is a terms that you have to say in your viva and also in your exam papers because it is in a most accepted terminology and everyone will be relying on these GPT terms only. And it is a direct attachment or connection of the osseous tissue to an inert alloplastic material without intervening connective tissue. And the process and resultant apparent, that is like the process through which the direct attachment is achieved is called as the osseointegration process and of exogenous material surface and os-bent tissues without intervening fibrous connective tissue are present. Interface between the alloplastic materials and bone should not be present. And see, the success of implant will roam on three factors. First thing is the host factor, that is patient factor, patient's medical conditions, and also local condition, that is quality and quantity of bone that is present. And then the implant, that is like implant design and also implant surface characteristics. And third one is the surgical procedure that we perform. So totally we do have any three factors in our control, and third factor is a patient factor which is out of our control. But according to patient, we have to manipulate it. But if at all within the terms, if we cannot do it properly, then we can say that we cannot go for an implant. We can explain to the patient. According to American Academy of Implant Dentistry, osseointegration is a contact that is established without interposition of non-bone tissue between normal remodeled bone and implant, entailing a sustained transfer and distribution of load from the implant to and within the bone tissue. But it is not actually required for you guys. And it is also not required according to Zab and Alveston. But for you, just it is a brain marks definition and the GPT definition are sufficient. And bone healing, an injured bone heals by primary and secondary process. That is like what you have studied in the general pathology. That is like healing of the bone You might have studied, right? Similar thing that will happen. Primary bone healing occurs at the fracture site with a clean break because we are creating the fracture in this. Uh, we are getting a surgical osteotomy site in the bone, and thereafter we are placing an implant. In this type of healing, there is well organized bone formation with minimal granulation tissue formation, ideal in case of implants. And secondary healing occurs when a large defect or large fracture site precludes the close approximation of the two sides. And this type of healing is prolonged due to the infection and granulation tissue. If at all there is any infection that is intervening between the implant and the bone, suppose in this intervening tissue is present, then it is going to cause a secondary healing. And this type of healing may result in the fibrous tissue formation, which is called as fibro-osseous integration. Here you can see it is called as biological seal, and this is the osteointegration that has occurred with the implant to the surrounding bone. And over here, you can see the soft tissue contact over the area and alveolar bone and the mucosal epithelium. The bone healing around an inserted implant occurs in three phases. First phase, second phase, and third phase. In the first phase, there is injury. That is, while we are placing an implant inside the bone, suppose this is a bone, then we are, like suppose this is a bone, then we are creating an osteotomy site with the help of drills. And then the implant is placed in this area. So thereby injury phase that we have created. And second phase is the granulation phase, where 2 weeks, 3 days, third day to the 2 weeks after implantation formation of the local connective tissue. New capillaries and new supporting cells will be developing around the implant. And thereafter, the bone deposition is started. The initially formed bone is called as callus, which later on gets completely resorbed and replaced this cartilage with a osseous tissue, thereby resulting in the formation of lamellar bone. You can see over the picture the steps in bone repair and replacement of the fibrous tissue. That is like in the first 24 hours, we have placed an implant. Thereafter, the blood clot that is formed around the implant will be undergoing a neovascularization process, or it undergoes differentiation process, and thereby the blood capillaries will be developing around the implant and resulting into simple things that you have to understand is, suppose there is some barren land in a country. Suppose in a country there is some barren land, then what we have did, this island has been added to the country. Suppose I'm saying everything is hypothetical situation. An island is present, and then we have added this island to this country. Then what we will do? We will add the roads first, right? Because the transport should be increased. So thereby here also neovascularization will occur. That is like, firstly, neovascularization, that is transport of the all the nutrient materials, that is like glucose, proteins, lipids, fats, and also the our immune cells should be going to this particular area. And this is facilitated by the neovascularization, which provides the roadways to this newly created surgical site. Thereafter, they do go and start acting their activity. That is like fibroblasts go and deposit the fibers, and osteoblasts go and deposit the bone, and whereas macrophages go and do the immunological functions. Like that, they will be doing each and every functions, each and every component which has each in their activity. They will be executing that. Okay, simple enough. Then, after a period of time, the complete deposition of the osseous tissue by this osteoblast will result in the formation of the bone, which is completely chemically interlinked between the bone and the implant. Because of the titanium is a completely biosynthetic material, that is like biocompatible material. Coming to the bone remodeling, that is like we have placed implant. Now the osseointegration has occurred over a period of time. It undergoes a remodeling, which requires a new bone formation around the fixture, or is also called as implant. See, implant or fixture, both are synonyms, and a process resulting from the remodeling within the bone tissue. Remodeling, bone resorption, and opposition helps to maintain the blood calcium levels and does not change the mass quantity of the bone. That's why we say that we cannot place an implant in the low calcium level patients, because the bone is going to get resorbed, because to maintain the calcium in the blood, the bone will be resorbed. So thereby the implant is going to fail. In spongy bone with an abundance of osteoblasts and osteoclasts available, remodeling occurs on the surface of the bony trabeculae. Thereafter, the conditions affecting the bone repair at the implant site is, in principle, bone effect may react in three different ways. That is, fibrous tissue formation may occur, or dead bone may remain as a sequester without repair, and new bone healing or osseointegration. We will be discussing each and everything in detail. Bone repair of the necrotic implant cortex will depend on the presence of adequate cells. That is like, see, all the necrotic cells, all the necrotic bony parts that we have removed, we have created during the surgical drill procedure. It should be eliminated with the help of an osteoclast. Osteoclast cell comes and resorbs the unwanted bony fragments, and osteoblasts will start depositing the bony osseous tissue on the already present implant. And adequate nutrition to these cells is achieved by the help of neovascularization and adequate stimulus for the bone repair. Theories of bone to implant interface. There are two theories. This is one of the very, very, very important thing for the your UG or also for the NEET MDS. That is like, see, fibro osseointegration and osseointegration. Suppose there is any discrepancy, that is like we have placed an implant, it has no micro motion, which has assured a primary stability. Then it will develop into an osseointegration. If at all the implant has some micro motion, or any kind of patient as in this bruxism patients, what happens is, suppose in the maxilla it is completely edentulous, in the mandible their teeth are present. So what they will do, with the help of this lower mandibular teeth, they will try to grind the over the mucosal tissues. After we have placed an implant, they will be trying to rub as their habit is present, so thereby resulting into the creation of abnormal forces, resulting in the formation of fibro integration. See, this is one of the factor I'm saying, but it can be of many factors. So, fibro integration generally occurs when there is some any kind of discrepancy, or any kind of like not properly placing an implant in the bone. Then only fibro integration, or also some kind of infections if at all present. Whereas osseointegration, this was given by Brainmark, Zab, and Albertston, and fibro one was given by Linkow, James, and Weiss also. Uh, Fibro integration. See, fibro integration refers to the presence of connective tissue between. See, simple thing, that is like implant, bone, and there is a fibrous tissue. So thereby fibro integration. That means fibrous tissue integrated into the osseous tissues. So thereby fiber and bone. These two things. And in this theory, collagen fibers function similarly to the Sharpie fibers that are found in the natural dentition. That they thought like that. The fibers affect bone remodeling, where tension is created under optimal conditions. But the failure of this theory is that it is very important, you need to mention about it. That is like, see, it was felt that peri-implant membrane gives a cushion effect. That is like in the first clause also I said that is like they thought that implant, suppose there is a 100 newtons of load is acting, suppose, then all the force will be transmitted to the surrounding osseous tissue in the osseointegration. Whereas in the fibro-osseous theory, they thought that they're going to be damping, they're going to be damping of the forces that are going to be transferred to the bone. However, there was no real evidence that is found that these fibers function as in a similar to the PDL fibers. Hence, when in function forces are not transmitted to the fibers, thereby this theory was rejected. Simple thing. They thought that they will act as a PDL fibers, but it didn't act as a cushioning. This is very important thing that you have to mention. That is like fibro-osseous theory, as they thought that it will act as a cushion effect, but it was proved to be false. That is, it cannot have any cushion kind of effect. So thereby resulting in a failure of this fibro-osseous theory. Now the theory of osseointegration, that is like method it all, redefined and subdivided the term osseointegration into adaptive osseointegration and biointegration. See, you people don't need in detail, but you have to mention about the terminology that is like Um, adaptive, you have to mention about the adaptive osseointegration and also biointegration, which are the two parts that is present in the osseointegration. Where adaptive osseointegration means approximating surface of implant without appearance of tissues at the light microscopic level, whereas biointegration means it's a direct biochemical bone surface attachment at the electron microscopic level. The only difference is the electron microscope and here light microscope. Rest all is the same. That is like a direct attachment. Okay. Thereafter, unlike fibro osseointegration, osseointegration was able to distribute the vertically and slightly inclined loads more equally in the surrounding bone. That is like, see, implant is present. It is a bone. This is an implant. Then all the forces are distributed throughout the bone. So thereby, there is no any discrepancies that are occurring. So all the forces is transmitted to the bone, which can bear the occlusal loads. To obtain a successful osseointegration, Brainmark and Kovac proposed the numerous factors. According to the proponents of the oxide layer, should not be contaminated or else inflammatory reaction will occur. See, sterilization is very, 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 very important thing when we place an implant. Of the implant and also of the surgical side and also of a gloves, everything. Because like if at all while removing the implant from the implant box, if you it should not touch even your gloves also. It should be directly placed in the socket of the patient. That's it. Very, very much we need to follow the sterilization protocol. And the temperature during the drilling should be controlled by copious irrigation. That is like, see, while we are doing the osseo, that is like doing the osteotomy, or we are drilling the site of the bone, we should be done with about a lot of irrigation with the help of saline. Saline is used, not water is used, because saline, as we are doing the osseous tissues, saline which has a pH that is equal to the our blood also. So thereby no issues will occur. So that's why we have to use the saline while we are placing an implant to act as a coolant, just like you use an aerator, right? Where water is used as a coolant because you are doing in a on the tooth surface. Similarly, as we are doing in the osseous tissues, where the water can be absorbed by the our tissues into circulation, so thereby saline is used. Simple thing. And a lot of saline should be used. That is a copious saline. And in the last class, I forgot to mention that is like D1, D2, D3, and D4 type of bone. In this D1 type of bone, we think that is a very good bone because it has a very good cortical support. So thereby it will give a good support to the our implant. But it is not actually, it is a D2 type of bone because in D1 type of bone, which has a much more density, it is highly density. So thereby it will be, while we do an surgical osteotomy on the surgical side, we have to apply a lot of pressure and lot of heat is generated. That is like there is a heat generation occurring at the implant site. So thereby there is going to be certain damage to going to be occur. So that's why the D2 bone, which is having an optimum level of speed and also like a optimum level of density. So thereby we can place an implant without creating any kind of heat. See why we use aerator water in the aerator, because when we rub or when we erode or when we upgrade the tooth by with the help of aerator, it is going to be a lot of frictional heat is going to be generated. That heat is counterbalanced or it's nullified with the help of water in the aerator. Similarly, that heat should be, while placing an implant with the help of surgical drills, should be nullified with the help of saline. Preferably, cold saline should be used. That is like if we are placing an implant at 5 o'clock, then the saline bottle that we take, right, it should be placed in the fridge at 3 o'clock so that at least 1.5 hours of cooling, normal cooling, not that completely ice, normal cooling should be present so that it will be act as a furthermore coolant should be will be present. First month of the fixture insertion is the critical time period for the initial healing. And when the loads are applied to the fixture during this period, primary fixation is destroyed. Thereby, secondary fixation is assured. Thereafter, the mechanism of osseointegration is that the mechanism of osseointegration, the Davis in 1998, and mechanism of integration was given by Osborne and Newsley. You can see the integration that is given by Osborne and Newsley is that the term distance and contact osteogenesis were the first described by Osborne and Newsley in 1980 and refers to a relationship between the forming bone and surface of an implanted material. Distance osteogenesis is a new bone is formed on the surface of the implant in the peri-implant site. The existent bone surfaces provide a population of osteogenic cells that lay down the new matrix, which as osteogenesis continues and encourages the implant itself. And contact osteogenesis is not at all required for you guys. Just you need to remember that is like distant osteogenesis and contact osteogenesis are the two terms that are present. And whereas the mechanism that was given by Davis is that osteoconduction and de novo bone formation. This is very important thing. Osteoconduction. The term osteoconduction refers to the migration of the differentiated cell. That is like it is being conducting from one side to another side with the osteogenesis cells move to the proposed side. And these cells are derived from the remodeling sites from the undifferentiated perivascular connective tissues. More complex environment characterizes the pre-implant healing site since this will be occupied transiently by the blood. And migration of the connective tissue cells will occur through the fibrin that forms during the clot resolution. In the fibrins, the reaction product of the thrombin and the fibrinogen released into the healing site can be expected to adhere to the almost all surfaces. See, the fundamentals of the implants lies from the your first year subjects, that is like anatomy, physiology, biochemistry, and also your general pathology, microbiology, everything. See, why we study these subjects are also because like each and every subject has its own clinical significances when you go for clinical practices. Because see, microbiology, these are the organisms that are going to act and create any kind of discrepancies. And pathological point of view, we should be knowing all the biomechanisms that are occurring. That is like how the healing occurs, how the that is like healing in the fractured bone occurs. Because similar thing will be occurring in the implant also, which is the bone in the implantology or in the dentistry. De novo bone formation. Prerequisite of de novo bone formation is that recruitment of the potentially oxygen cells to site of future matrix formation and differentiated oxygen cells which reach the implant surface initially. That means the cells which are differentiated will come to contact with the implant and thereafter they secrete the collagen-free organic matter. That is like, see, osteoconduction, where one cell is transported from one side to the particular required site. And then this cell has been transferred. This act by depositing the initial bone formation by releasing the calcium, phosphates, which gets mineralized. So thereby resulting in the formation of the initial bone. And thereafter final calcification that occurs over a period of time during the healing phases completes. Coming to the stage of osseointegration, this is you need to mention in your theory exam. That is like stage of osseointegration. They are surface modeling or remodeling. Surface modeling is going to be stage 1 and stage 2. Bone callus, stage 2 is a lamellar compaction. And remodeling or maturation is going to be interface remodeling according for the 6 to 18 weeks and a compactor maturation. It is going to be 18 to 54 weeks. This you have to mention to get a good marks. And stage 1 is a woven, that is like, see, these people doesn't need to mention. I'm just saying in stage 1 the woven bone is formed because we have created a blood clot which is gets ossified and results in the formation of initial bone, that is woven bone, which later on there gets mineralized, resulting in the formation of lamellar compaction. Thereafter it undergoes interface remodeling, that is interface between the implant and the bone will undergo remodeling, results in the compact bone formation. So thereby, the implant is highly successful by the end of 54th week. Thank you. This is Dr. Vikram. Still sorry. Does anyone have any doubts? Anything that is like you need to understand? Any doubts were present by any of guys? That is like if you want to get explain any topic further in detail, you can ask. No, sir. No, sir. Okay. So with this, we can close the. Can we close the session? Okay.
सो रहा था उसका क्या होमवर्क है निकाल के देखो
Abdul Rahman, you have joined at the ending time. It's okay. No issues. We will be sharing this record video also, so you don't need to worry. This is Dr. Vikram. Thank you. Take signing off. Okay, no need to worry, Abdul Rahman. You can log into our website, and thereafter you can see the our recorded classes of this topic. Okay.
Uh, okay, sir. Thank you.
Okay. From the next time onwards, kindly join on the time. Okay.
Okay, sir.
Okay. Right. Bye.